Welcome back to Good Law, Bad Law. You know, in the last 10 years, you would be hard-pressed to find a hospital or a doctor's office that doesn't use electronic medical records. It's been completely pervasive and taken over all aspects of medical record keeping. Gee, that sounds boring. It's really not, actually. It's hugely important in every way, from the way doctors interact with their patients, the way patients access their own important medical information, the incidence of medical errors that can occur because of medical records now being on computers, the rise of security hacking of hospitals' medical records and selling your personal data to whoever they sell this stuff to. There are a lot of problems that have created with the promise of great advantages from this move to electronic health records or electronic medical records. My guest today is Sharona Hoffman, and she is a professor of law and bioethics at Case Western Reserve University in Cleveland. She's also worked with the CDC in Atlanta. She knows an awful lot about this. And I'll tell you, I learned a lot, and some of it I wish I didn't know, because it's really, really important and difficult and controversial stuff. I know you'll enjoy learning about this important issue. Stay tuned. It is an old and tired joke that doctors have terrible handwriting. And I can tell you, because I've looked at literally thousands and thousands of pages of medical records, and it is true. They have horrible handwriting. There's the odd physician who has handwriting like typewritten script, but most of the time, not so much. And that's actually one of the problems that a move towards electronic or digital medical records was supposed to cure, as well as all of the potential problems, medical errors, miscommunications about medications and so on. That electronic medical records was supposed to fix that and improve medical care and improve communication and reduce costs. The question is, has it done that? And to help us with that is my guest today, Sharona Hoffman, who is the author of a book called Electronic Health Records and Medical Big Data, and a professor of law and bioethics at Case Western Reserve University. Sharona, thank you so much for being on the podcast today.
My pleasure.
How did I do with that intro? That kind of sets the table a little bit for us, and why in the last, 20 years, but really especially in the last 10 years, there's been a near universal move to digitalize hospital and physician office medical records.
Yeah, that was a perfect introduction. Very good. And yeah, it really took off with the Obama incentives. The Obama administration established the meaningful use regulations and the incentive program to get people to embrace health information technology. So you could actually get some payments if you adopted an EHR system and used it appropriately.
So, and I know this from reading through your book yesterday, that despite the idea of computers being able to help us make so much more readily available and accessible and interchangeable medical records, it took a long time to get buy-in to this, and now I don't think, perhaps except in the most remote parts of the country, you can be a patient in a clinic or a hospital or a doctor's office and not have your care being intimately connected to a vast computer network. I mean, it's become almost entirely used and implemented today. Is that right?
Yes. I mean, they are universally used, so that incentive program was effective, and really you seem completely antiquated if you don't have an EMR system, though there are some practices that have intentionally avoided it because it is complicated. They have fallen short of their promise, and so there are certain doctors that say, I'm going to do this the old-fashioned way and just use handwritten notes. And there are also people who are worried about privacy, and so that's a selling point. No, I still have handwritten notes, and I just lock them away in the file, and you don't have to worry about hacking and so on.
Right, and that's become a really big problem in the last couple of years. So I thought it would be useful, because we have an audience of both those involved in the legal profession somehow and many, many, many thousands of listeners who are interested in the law but are not lawyers. So I thought it would be helpful to maybe break up our conversation about this and look at the advent of electronic medical records from the healthcare provider's perspective, what's been good about it, what's not been so good, from the patient's perspective, and then maybe thirdly from the perspective of the law, because you raise issues of privacy and security, and that raises an awful lot of legal questions that major health systems down to individual physician offices are confronting with the risks of cyber hack and other breaches of security and the breaches of confidentiality that go with that. So, I think that from each of those different perspectives, there's a lot to learn here. Do you want to start by telling us a bit about what your research and your studies have shown? Because, of course, technology can cure some problems as it creates other problems. And I think that's probably true here when it comes to electronic medical records. What have you found from the perspective of the healthcare providers?
It has helped in some ways, but a lot of them are quite disappointed. It certainly is meant to give you a comprehensive record of the patient that is easily searchable so that you can easily see what their cholesterol results or blood pressure was, over the years. And the promise was it would make everything more efficient. You would just be clicking on boxes and typing things in, and it would all be there. I think a lot of physicians have found numerous problems. First of all, documentation now takes a lot more time than it used to because
Wow.
They can no longer jot down notes or dictate notes. You have to work with the computer. And there have been studies that have shown that for every hour with a patient, they spend 2 hours on documentation,
Wow.
which is just astounding.
That is so counter to what you'd think. I mean, the computer is supposed to make life easier, supposed to help us be more efficient, not have physicians, in this case, spending more time away from their patients.
Yeah, I have an article that came out this summer, and I've been giving some talks on physician burnout. And a number one cause for that problem is EHR systems because they are difficult to navigate and they just take so much time. We also have failed to establish interoperability. And so patients
What does that
who
mean?
get
What does interoperability mean?
That all EHR systems can communicate with each other so that if a patient has seen a doctor at a different facility with a different network, ideally with proper authorization, you should be able to access those records. But that is not the case. You still have to get copies sent and so on, and so we haven't achieved the efficiencies that were hoped for. The hope was for a national health information network where if you had authorization and passwords, you could click in and see everything about the patient. And that is far from the case right now.
Why is that, Sharon? I mean, I would think that would be certainly in the patient's best interest and also make life so much easier for providers if that existed.
Right. So the vendors don't like that idea because then you could very easily switch from one product to another. And right now it's extremely difficult to switch among products made by different vendors. You kind of have to start over. it also turns out computerizing health records is just way more complicated than computerizing bank records or any other kind of records. So one problem is different practices use different terminology. And so it doesn't translate well. So if you see MS in the record, you don't know if that's multiple sclerosis or magnesium sulfate or any, other meanings.
Right.
And there are multiple meanings to terms.
It could have different meanings in different specialties of medicine, or it could simply be the quirks of a particular physician in the same practice. They may just abbreviate things differently.
Exactly.
Yeah.
And so, it would be very difficult for one computer to read and translate the record from another computer system. So it has just proven much more complicated.
I concede then one of the other trends we think we've seen in medicine is the rise of these vast healthcare networks. You'll have 20 years ago, it was just a single hospital, but now it's part of fully integrated health system with pain management clinics and imaging centers and, all kinds of multiple hospitals. I would think within a health network, as those have become for a lot of people what they're used to seeing and how they're used to getting their medical care. I would assume you would get interoperability, the ability to communicate among different facilities that are part of a same big network.
Yes, I think we probably do have that capability, but in a lot of cities, for example, in Cleveland, you have at least two big networks, and people have doctors at each. Here it's Cleveland Clinic and University Hospitals. Or you get a diagnosis from one, and then you go get a second opinion from the other. And so we still have interoperability problems.
What about cost, Sharona? That was one of the big promises of EMR, electronic medical records, that it was going to lead to all kinds of efficiencies. It was going to allow you to capture billing charges more effectively. Has that promise borne out?
So the studies do not definitively show cost savings. Again, because of some of the problems of interoperability and doctors having to spend so much time on documentation and so on. There probably has been better charge capture, but that raises costs. And I've heard some people say actually the primary purpose of EMRs is charge capture. And so instead of just saying I treated the patient for the flu, the doctor can now say, I looked in the ear, that's $50. I looked in the throat, that's another $50. I tickled the feet, that's,
Right.
And so
I'd like to have a doctor who did that.
I would not.
I'm just kidding.
And so, in fact, sometimes it enables higher charges for patients.
Yeah. Well, I was just telling somebody this morning about that because I read that in your book, and I was fascinated, but also deeply disturbed about this. And I think we need to say a bit more so people understand what this means, because there's also this idea of upcoding, and
yes.
Another word for upcoding, if you get caught doing it, is fraud. And you talk about how some studies have shown a huge amount of Medicare spending, which leads to a huge amount of money, is thought to be attributable to upcoding or fraud. And so how do electronic medical records lead to greater incidence of upcoding?
Because you just have to click on a box or on a drop-down menu. And so I think maybe psychologically it's just easier to click one box rather than another instead of having to handwrite it out. And it also gives you suggestions. So whereas you might not have thought of calling it an acute condition, well, it suggests that. So why not call it an acute condition if you can get paid a little bit more?
Mm-hmm. Well, and I can tell you, I do a lot of medical related cases, so I've taken depositions of lots of doctors, and over recent years have had to go through many, many electronic medical records. And I can tell you, whether we would call it fraud or just kind of the way business is done these days in hospitals, when you actually have them explain how they created a particular record. I mean, if I'm looking at a client's record, a patient's record, and going through a progress note by a physician, meaning the note they used to describe information they got from the patient during a visit and what their plan was for treatment and so on. When you have them explain how they used the electronic medical record system to create that note, often I find they're telling me there's just huge parts of the note that just get imported into the note automatically by the computer. If I ask, for example, tell me what you did in the section here called physical examination, where you're supposed to go through all the patient's bodily systems and note your findings. I say, well, what did you do to examine the GI system or the heart system or the lungs? They say, well, I didn't really do that. It just comes into the note from the computer system, which is a problem in a lot of ways, because another healthcare provider looking at that note may assume that the physician actually did examine those things and didn't just, sort of cut and paste them or hit a button on a pull-down menu and have that now appear in the note. But it also creates the impression that they did a lot more during that visit than they actually did, and then they can charge more for that interaction.
That is correct. And another problem with that copy and paste function is that if it's not carefully edited, it actually introduces errors into the record. And so there are anecdotes and cases where the record for 7 straight days says this is the second day of antibiotics, because that's just pasted in. And that can lead to huge errors, because the doctor would think it's only the second day when it's really the 7th day, and the patient isn't getting better and they need different antibiotics, but the doctor thinks, well, let's just give it a few more days. So that's very dangerous, that copy and paste capability.
Well, and I have another case right now, in fact, where a doctor did a surgery, and while the patient was in recovery and before going to the floor to be cared for by the nurses, the doctor thought he was inputting an order for antibiotics because the patient had an emergency surgery and needed to get antibiotics, but hit the wrong button on the system, and actually no sooner did he enter the order than he hit a button and canceled that order. So the patient didn't actually get antibiotics for a number of days until they figured this out. So, which to me is concerning, because I know from other big studies like the Institute of Medicine study that came out a number of years ago, that a huge number of medical errors that take place are medication-related errors, where the wrong dose or the wrong drug is given, or there's an interaction that wasn't appreciated. And I always thought electronic medical record keeping was meant in large part to reduce, if not eliminate, those kinds of errors, because now you're looking at text and not someone's handwriting that could be misinterpreted. But I think from reading your book, that promise hasn't been kept either.
That is correct. Electronic health records eliminate the problem of illegible handwriting, but they create opportunities for a lot more errors. So as you said, inadvertently canceling an order, inverting numbers and putting, 5 times as much of a dosage as the patient should get. There are cases where the default is in kilograms, but the doctor is typing in pounds, and the dosage is determined by the patient's weight, and you get egregious errors that way. And so if the defaults aren't what the doctor thinks, or if the doctor is just not that savvy with the computer, you get a whole lot of errors, some of which can be catastrophic. And of course, if there's a computer shutdown, which we all experience, that can paralyze the entire hospital.
Well, all right. So what about from the we've sort of talked about it because there's overlap here. The patient's perspective, obviously, it's the patient ultimately who is going to suffer harm if there is some kind of error. You've given us some examples of that. But one of the promises of electronic medical records from the patient's perspective was ready access to their own medical records, to important information, whether it's the results of a test that they underwent or instructions from a physician about medications and dosage and things like that, as well as access to at least information that the physician wants you to see, as opposed to what a patient might find on the internet, which could be accurate or could be inaccurate. What about those kinds of issues from the patient's perspective? What have you found?
Right. So a lot of what you're talking about is called the PHR, the Personal Health Record. And certainly, if that's done well, it can give patients information much more quickly than they would get from having to call the doctor or wait for the doctor to contact them. And so a lot of patients like that. Some practices are not as good at posting information as others are, and some of what you see there might be incomprehensible to you, but it is convenient, and it's certainly nice to get test results very quickly. It reduces anxiety and so on. But patients also complain that during the encounter with the doctor, they feel the doctor isn't paying attention to them because the doctor is so concerned about the computer and about getting the documentation right that sometimes they barely look at the patient, don't really examine the patient thoroughly. I've heard people say, well, the real patient in the room was the doctor's computer. And so there's some resentment. And I think doctors, in fact, it's very tempting to be less attentive to the patient. I've heard physical therapists say, I used to give the patient an exercise and watch every repetition in order to make sure they're doing it correctly. And now I give them the exercise, I turn to the computer, I do some documentation, I look at them after 20 repetitions, and I go, oh my goodness, you're doing it all wrong. And that's really not to the patient's benefit.
Right. That's potentially very dangerous. I mean, yeah, it's sort of like trying to talk to someone when they have their face in their phone. You don't really feel like it's a real conversation, and how can they possibly hear you if they're paying attention to whatever's on their screen? So I could see doctors and patients becoming potentially very frustrated with that. I mean, that the patient-doctor relationship and the whole interaction is supposed to be at the heart of good medicine. Picking up on subtle things that you might not necessarily hear in the words that a patient says can be important, and sometimes even more important than what the patient is saying.
Right, but if the doctor's not looking at you, the doctor will never pick up on those things.
Well, so far I'm not really getting a good feeling about electronic medical records. I know it's sometimes easier to focus on the negatives, but I mean, are there? It does feel like this is the world we now have. There's no going back to handwritten records at this point. I can't imagine that.
Correct. Nobody thinks that will happen.
Yeah. So, I mean, are there good things to say about this, this conversion to EMR? And it's okay if no, but I mean, I'd like to, if there is something, we should say it.
Right. I mean, there's always room for improvement. Mm-hmm. So if we improve the technology, it might meet all those promises. You definitely don't have the problem of illegible handwriting. Doctors who are really good at working with the computer are able to look up your history more easily than they might if the paper record is really messy or really thick. Doctors that are really good at this sometimes sit with the patient. Just the communication can improve the situation. So if you sit side by side with the patient and you say, well, let's look at the computer and see what your cholesterol was last year, sometimes the patient feels more involved and feels like this is a tool that brings the patient closer to the doctor. And of course, the vendors just need to keep working on making this easier to navigate and making sure that it helps rather than hinders doctors. One thing that I talk about in the book and in later articles is that the certification process for electronic health record systems really is minimal. It's not thorough enough. When we test a drug, we do years' worth of testing with real patients, and we pay close attention to adverse events. And we do not do that with electronic health records. We treat them like it's just a computer with some word processing, no problem. So one day of testing, not a big deal. And I think that we need to find a way to put them in real clinical practices, see what real users find when they try to use these systems, and address problems in advance before we launch these in the marketplace.
Well, and it sounds like from what you've said so far, there are improvements in the technology needed to deal with things inherent to medicine, like what you were saying before about different abbreviations meaning different things to different doctors and different specialties, but also changes in the way the technology is used. It's not just about data entry. It's about how, sort of like many people have criticized medicine today by saying that physicians have really stopped understanding the importance of bedside manner, and how important that is to the relationship. And it sounds like there are a lot of improvements that can be made through training and looking back on the experiences and trying to learn from them. How do physicians use it? Because I love the image you create of the doctor sitting side by side with the patient and going over the data with the patient, rather than just saying, "Hey, look it up on the on the medical records portal." It sounds like there's ways it could be used so much better, more effectively, really to everybody's best interest. And there's work to be done there.
Yes, and there's also work to be done with regulations. So we've probably gone overboard with quality measures, performance measures, the meaningful use regulations required all kinds of data collection and reporting and trying to get patients to look at different things on the computer. And I read that potentially there are 2,500 different quality and performance measures that healthcare providers might have to deal with in their careers. And we need to revisit those and make sure that we are only requiring what will benefit patients, what's outcome related, rather than data collection for the sake of data collection. And really pay attention to the regulatory burdens as well. They used to joke, it's not really meaningful use regulations, it's meaningless abuse regulations. So if doctors feel that way, there's a problem.
Well, let's the last few minutes we have together, let's turn to some of the more current legal issues that electronic medical record keeping raises. And I'm thinking primarily about security, data security, because we're talking about health records and some of the most private and personal information that exists on a person. And also, I want to touch on issues of liability. We've talked about that somewhat with the issue of medical errors, which of course can lead to lawsuits and lead to lawyers like me getting involved. But cybersecurity seems to be more and more and more of a danger. I mean, it feels like every week I'm reading an article about some hospital or health system that got hacked and released, X number of thousands of patients' personal and confidential data into who knows, the hands of the Chinese or the Russians or who knows where. How big a problem is that, do you think?
It's a huge problem. We have hacking, we have criminals coming up with all sorts of new ideas. There was ransomware a couple of years ago. I think that's still going on, where they would lock your computer and you had to pay a ransom in the hope that they would give you a decryption key. And regulations and protections really don't keep up with the creativity of wrongdoers. And so it is extremely difficult to make sure that your security is up to date and is as protective as possible.
Well, I mean, I know this as someone who runs a law firm, and we have similar concerns because I have sensitive client data, and we worry about the same things, ransomware and other types of hacking and phishing and all these different things. And I mean, we're taking steps. We're on it every day, every week. Now, I don't have as big an operation as a major health system, but I would have to imagine that this ought to be a top priority if you're going to have all your patients' most highly confidential and personal information. I would think that this wouldn't be something deserving of an afterthought, that it would be a top priority to invest in whatever is the most up-to-date and most secure protections against these things. It's happening every day. And I mean, I have to imagine it's just going to get worse and worse because there's real value to criminals in gaining access to this information.
Yes, and for a lot of practices, certainly the ones in big systems, and more and more practices are part of a big system. I think 75% of doctors work for a large employer. Certainly they have sophisticated IT departments, and they pay a lot of attention to it, and they have resources to invest in it, though whatever you do, it's imperfect because the next guy will find some new creative way to get access or to extort money. But to the extent that there still are smaller practices, independent practices, it is so expensive that it's very difficult to keep up and to make those investments. And if you can't hire an IT department, certainly doctors themselves are not often sophisticated about computer security.
Well, we talked about this a little bit, the role of these now very large companies that deal in electronic medical record systems, that are vendors to hospitals and doctors' offices selling these products, and not just the computer software, but training and support for all the people who will become users of the system. What type of liability issues do you see either now or developing in the coming years for companies, some of these big EMR companies? One of the names that comes to my mind is Epic, but there are others out there. I mean, could they be expected to not only provide the software but also to provide security over the data that's kept in their systems?
Sure. I mean, there's a lot of potential liability in terms of security, in terms of accuracy, if their systems are too prone to making mistakes or to misleading doctors so that the doctors make mistakes, there's potential liability. It depends on the contract. If the contract says we don't provide X, Y, and Z, then they're not liable for it. Some contracts, I believe, have immunity provisions that say if something happens, you agree that we will not be liable. Traditionally, some of these contracts had gag orders where they wouldn't even allow physicians to talk about problems that they had with the systems. I think the law is starting to address that. And also a lot of plaintiffs' attorneys, I think, are not that knowledgeable about electronic medical record systems and don't know that that is a target in litigation. And so they will just sue the traditional suspects, the doctor, the hospital, and so on. when the vendor is actually a deep pocket and the system may well have had something to do with the problem.
Well, I guess especially if you I just banged my microphone. I guess especially if you encountered a situation that was happening more than once, that was something you could describe as a systemic problem, not so much a one-off, like the case I was talking about earlier where the doctor just hit the wrong button. I mean, that might not be a systemic error unless there's poor training, unless it wasn't, there wasn't some continuing training that perhaps would have addressed that problem. But I imagine there are things, some of which you've described already, that could be described as more systemic types of problems that could at least raise the potential of liability on the part of the designer of the system, these big computer companies.
Yeah, and even canceling the order, if the system makes it too easy to cancel an order by mistake, that's a problem. There should be some safeguards to make sure that you're not canceling orders that you didn't intend to cancel.
So let me ask you then, in terms of looking ahead, what from each of these different areas that we've talked about, if you could wave your wand and direct where you think efforts ought to be directed to making improvements in the system, it's not going to go anywhere, but we can improve it. From starting with the healthcare provider's perspective, what would be, say, your top few priorities in terms of how to direct our energies towards improving the system that we're now all a part of?
Yeah, so there are just numerous avenues. One area that a lot of people are talking about is interoperability, that making sure that systems and different networks and facilities can work together and communicate together. Another is more thorough usability testing of the system so that before you market them, you've addressed some of the problems that are going to be commonly encountered. Focusing on making them as user-friendly and as easy to navigate and as efficient as possible for healthcare providers. And then the regulations, really paying attention to how burdensome the regulatory requirements are. Are there requirements we can eliminate? Are we collecting data just for the sake of collecting data, or is everything geared towards improving health outcomes?
I wonder, there's been a lot of talk, especially in the campaign this time, about Medicare for all or some other form of universal healthcare, single-payer systems, at least moving in that direction. Have you given thought to how a move like that would impact some of the issues we've talked about, the lack of full intercompatibility between different systems? If we had one system, would it be more likely to see that problem cured? Or would we have to kind of move to a single system of electronic medical record computer systems at the same time we move to a single universalized health system?
Well, it would make it easier to have a national health information network, I believe. And certainly if you had a single payer, they could negotiate with vendors and make demands on vendors that they move in certain directions and make particular improvements. So it probably would improve matters or facilitate improvements. The VA used to have a system that was hailed as a great system. I think they're actually changing it. But that was a model of a very large system where there was a single payer for the whole VA system. And they had pretty good technology that a lot of people were happy with.
Wow. That really surprised me because I don't often hear good things said about the VA medical system. But that's interesting that there's some experience there that perhaps could become relevant to the conversations we're having today about expanding that idea more broadly in our health economy. Okay, so what about from the patient perspective? I have to imagine many patients don't even fully appreciate that we are essentially on an electronic medical system, except I imagine those patient portals make it easier to schedule appointments and things like that. But, is it, do you have advice for patients that, things they ought to be aware of? Should people get copies of their medical records so that they have them? Is there concern about records being lost or accidentally destroyed? I don't know. What do you think patients ought to be aware of beyond what we've talked about so far?
Well, they ought to be aware that, we have electronic health records. I think from the patient perspective, you want doctors to try hard not to make the patient feel excluded during the visit and to still feel attentive. In fact, one strategy that is used is hiring scribes, where the scribes actually do the data entry and shadow the doctors, and then the doctor can go back to paying attention to the patient. So that's something for doctors to consider, actually, for the sake of patients, hiring scribes.
Right, because the physician then just has to review the note for accuracy, right?
Correct.
Spend a lot less time nose buried in a computer screen. That seems like a great idea.
Yes. And patients should be aware that healthcare practices now expect them to be looking on the PHR, on the personal health records, but as the population ages, that might be more and more difficult. A lot of older people don't want to look at the computer, aren't comfortable with it, don't know how to navigate that. And so patients should be aware that that may be the doctor's expectation, but they still have a right to call the office to demand to talk to a nurse. I have lots of people telling me, well, it's been 2 weeks, I haven't gotten my biopsy result.
Yeah.
Well, that's not okay. You should call them. You have a right to still talk to them. You have a right to demand explanations if you don't understand what you see on the computer. So from the patient's perspective, just keeping up the communication, keeping up your high expectations, and requiring responsiveness is really important.
Well, and on the last topic, and then I had kind of a PS question for you for the end, but on the issue of cybersecurity, it seems like we just need to see more dollars spent on prevention, on protection, on detection. These are the ways that you get ahead of the problem instead of figuring out where do I have to go to buy some Bitcoin to get my data back.
Yes, absolutely. And you have to hire really sophisticated experts who can anticipate problems, who can jump on problems when they see them and not react days later. So that's an investment that's very significant, but absolutely necessary, and you can't ignore it. It's as important as having good medical equipment.
Well, here's what I want to finish with, Sharona, because I note also from your bio, in addition to your teaching duties at Case Western and your writing and research and all, that in 2014 you were a distinguished scholar in residence at the Centers for Disease Control and Prevention's Center for Surveillance, Epidemiology, and Laboratory Services. And I imagine those folks that you worked with a few years ago are really busy right now trying to figure out how to restrain the spread of the coronavirus that has the whole world talking and pretty worked up right now. I have to imagine that a national electronic medical records database or accessibility of medical records across the country from a surveillance point of view would be pretty valuable right now. If it existed.
Yes, it would certainly be helpful. There are duties, of course, to report infectious diseases to public health authorities. So they should be getting reports regardless of the EHR. People shouldn't be terrified that just because we don't have good interoperability, the CDC is going to be paralyzed and ineffectual. They will get the reports, but being able to look at records easily, being able to investigate, is very, very important.
But I would still think, though, in a couple of different ways, how much more valuable and efficient and quick we could be about a problem like we're seeing right now if we had one database that someone in Atlanta could go to instantly. Because if on the one hand you have local hospitals who are obligated to report infectious disease incidents in their facilities, but they're reporting up primarily to their state health authorities, right? And then the state has to report up to the CDC. So you'd be eliminating a couple of administrative steps if someone in the CDC's offices in Atlanta could just look, like that and get a snapshot from across the country.
Possibly. Actually, that brings up another point, which is you have to make the records easily searchable.
Yeah.
And the search technology is also imperfect. So it's still hard even for doctors to find data in a single patient's record, let alone 300 plus million people's records. Hopefully with something like coronavirus, the reporting happens very quickly and efficiently, but it would be helpful for public health authorities to be able to search. Actually, when I was there, I've been there twice, so one of the times there was a big E. coli outbreak, and the way they solved it was they took everybody's shopper grocery loyalty cards, and they were able to see that the common item that was purchased among the patients that had this E. coli was Dole spinach. And I don't like spinach, so I was happy that was it. But yes, that kind of computerization was invaluable because they were able to recall it and stop people from buying it, and the outbreak stopped very quickly.
Wow.
And so that shows you the power of computerization.
Well, so all is not lost with electronic medical record keeping then. There's a lot to hope for still, even though there's a lot of work to be done to make the technology work better, improve the technology. What a great conversation, Sharona. Thank you so much. Sharona Hoffman, Professor of Law and Bioethics at Case Western Reserve University. That's in Cleveland, right?
Yes.
And also the author of the book we've been talking about, Electronic Health Records and Medical Big Data. We'll post a link to your bio, Sharona, in the description of the episode. I assume on your bio there can be, people can find more information about some of your writings, some of the articles you've done since the book came out. And we'll be getting this out to people very soon. And I want to, again, thank you so much. What a great conversation on a really important topic.
Well, thank you very much.
I hope you enjoyed our time together. Thanks again.
My pleasure.